Hi, this module is to introduce you to the topic of genetic testing of minors for adult onset diseases. This module is an introduction and will cover a lot of the basic information related to this topic. We also will discuss a case example. We encourage you to think about the case on your own and discuss with your fellow peers. This module will discuss the following topics: genetic testing, predictive versus susceptibility testing, adult onset diseases, existing guidelines for testing minors for adult onset diseases, arguments for and against testing minors for adult onset diseases, and lastly, a case example to have you think about whether minors should or should not be tested for adult onset diseases. First, let's talk a little bit about genetic testing. So, what is genetic testing? Genetic testing is used to look for changes in one's DNA and whether or not that change can be harmful to the individual. All cells in our body have over 20,000 genes, and often there are changes in the spelling of these genes that are unique to us as individuals. Sometimes these changes can be harmful and lead to disease, and that is what we are looking for. Genetic testing can be useful for providing a diagnosis, changing medical care plans, adapting cancer screening and treatment plans, and many other applications. Genetic testing is also performed for different diseases in different settings. Testing options include, but are not limited to, newborn screening, diagnostic testing, carrier screening in pregnancy, prenatal testing, assisted reproductive testing, predictive testing, and susceptibility testing. The last two are two tests that come often with testing minors for adult onset diseases. So let's talk more about predictive and susceptibility testing. Predictive testing identifies individuals who are at risk for developing a condition at some point in their life. Testing for Huntington's disease is an example of predictive testing. Individuals with mutations in the HTT gene means the individual will develop Huntington's disease, which is a severe and progressive brain disorder. The test, however, cannot tell us the exact age of when an individual will start to experience symptoms. On the other hand, susceptibility testing identifies individuals who have a mutation in a disease-causing gene, but may not necessarily develop the disease. Here, the question is not when the individual will develop the disease, but if. For example, having a mutation in the BRCA1 or 2 gene increases the risk of developing breast cancer. However, having a mutation in one of these genes does not mean the individual will develop breast cancer. Other environmental factors such as smoking, chemicals, and pollution increase the risk of breast cancer occurring in these individuals.
Let's discuss what an adult onset disease is and why children may be tested for these conditions. Adult onset diseases are conditions whose symptoms appear later in life. Some examples include Alzheimer's disease, which is a type of dementia affecting memory, thinking, and behavior. Huntington's disease, which we discussed previously, and hypertrophic cardiomyopathy, which is a condition causing thickening of the heart, making it more difficult for it to pump blood. In the United States, a minor is an individual who is under the age of 18 years old. The question you're probably wondering is, why would a child not be tested for an adult onset disease? This slide lists a couple of examples, but there are many more. One reason is testing may induce worry or anxiety. Other reasons include the idea that minors are unable to give informed consent, so the decision is left to the parents. Thus, is the minor truly consenting to testing, and does that take away their right to know? Currently, most of these adult onset diseases do not have treatment and do not have an exact age of onset. This can lead to further discussion on whether testing a minor for these conditions is ethical. So is there anything that can help in this decision? There are professional societies who have released position statements on this topic. The National Society of Genetic Counselors, or better known as NSGC, released a statement in 2017 that discourages testing a minor unless it impacts childhood medical management. NSGC emphasizes patient autonomy or the right to choose and states that waiting until a minor can weigh the risks, benefits, and limitations is best. Some testing may find secondary findings or findings that are not related to the reason for testing. It is important to ensure that the minor fully understands that these results are possible and how these results would impact their emotional and physical well-being. It is possible to delay disclosing secondary findings until later on, but a plan should be put into place on how to share these results later when the minor is of age. Overall, it is recommended that prior to testing, individuals meet with a genetic counselor or a certified healthcare professional. Another professional society, the American College of Medical Genetics, or better known as ACMG, echoes the recommendations of deferring testing of minors. Even with parental consent, a child who does not provide assent or approval should not be tested. Testing should wait until the child is mature enough to assent. The ACMG emphasizes that the genetic information discovered belongs to the child, and results should be shared with the minor at the time of testing or at a defined point of time in the future. This is why genetic counseling is vital to this process.
Next, let's talk about the arguments for and against testing minors for adult onset diseases. Some of the biggest reasons for testing minors include psychological relief. Sometimes knowing this information can reduce uncertainty and anxiety. It takes away the feeling of what if that some minors may have, reducing the constant worry that they will develop a disease. It also may even help someone adjust psychologically, just knowing what may affect them in their future. Similarly, having an answer can help someone plan their life, reproductive options, and inform their family. However, testing minors for adult onset diseases may also be considered harmful. A parent would have to consent for a minor to be tested. Therefore, the minor's autonomy has been disregarded. Is this truly the minor's choice if the parent ultimately makes the decision? Is a minor fully capable of providing true informed consent and understanding all of the risks, benefits, and limitations of genetic testing? It also makes one think about the results disclosure. The results will be disclosed to the parents, which once again ignores the autonomy of the patient and the patient's privacy. The minor would then have no control over whether or not the parents share the information or to whom. Perhaps the parents having the knowledge that a minor is likely to develop a disease will change how they interact and treat them. One main question is, will the minor be treated differently than their siblings or their peers because of a diagnosis for an adult onset condition? Testing can also put the minor at risk for genetic discrimination for future insurance or even some employers. Beneficence and non-maleficence are ethical principles in healthcare, meaning to do good and to do no harm, respectively. By providing this information, is it really beneficial to a minor who cannot seek out medical treatment at their current age or even at all? Adult onset conditions being tested, such as Alzheimer's disease, typically don't have treatments or cures. Other conditions, such as breast cancer, that do have medical interventions, often are not available until adulthood. One also has to think whether this does not harm. Results could lead to stigmatization or isolation. This could include feelings of poor body image, unworthiness and shame, or poor self-esteem. Individuals could even feel survivor guilt if they do not have a mutation in a gene, but their family member does. On the next slide, we will present a case example. Tom's father was diagnosed with Huntington's disease at 48 years old. Tom is worried about his 2 children. He goes to see a genetic counselor to get testing for both his children and himself. Think about all of the information that we have reviewed today. Feel free to reference any of the previous slides as needed, but keep in mind that Huntington's disease currently has no cure and no treatments available. What are your thoughts about testing Tom's children? Do you think the children should be tested? Why or why not? If you're interested in more information on ethical considerations, check out our other modules. Thank you to the students at Long Island University Post Genetic Counseling Program, and thank you to our advisors.